Hello, this is Dr. Tony Clark with learninganesthesia.com, and today we're going to talk about postoperative nausea and vomiting. Most of the information I'm going to present comes from an article in Anesthesia and Analgesia in January 2014 titled Consensus Guidelines for the Management of Postoperative Nausea and Vomiting. So let's dive into the risk factors that are very simplified for adults, and we'll talk about the drugs you typically give for said risk factors, and then we'll move on to kids and do the same thing because the risk factors for adults and kids are different. So first off, for adults, the simplified way to think about it is that there are 4 risk factors, 4 for adults and 4 for kids, that increase the risk of postoperative nausea and vomiting. The first risk factor we'll talk about is the patient-related factors. That is female gender, history of not smoking. I said not smoking. It's interesting that a history of not smoking actually increases your risk for postoperative nausea and vomiting. And the third risk factor is a history of postoperative nausea and vomiting. Then the last is the environmental factors. That is history or current use of high-dose opioids. So whether that is the patient is currently taking high-dose opioids or they have to receive a lot of opioids during the surgery or in the PACU for pain control. Those are the 4 simplified risk factors for adults that increase their risk for postoperative nausea and vomiting. There's other risk factors, and I'm going to list them here. And evidence is plus or minus on these. A history of motion sickness, use of volatile anesthetics, or nitrous oxide as well, the type of surgery being gynecological, urogenital surgeries, and laparoscopic surgeries, causing higher possible increased risk of nausea and vomiting. General anesthesia versus regional. General anesthesia having an increased risk, regional having a decreased risk. And the duration of the surgery. Longer procedure having an increased risk of postoperative nausea and vomiting. So if we take these simplified 4 risk factors for adults and we make a table down below of the 4 risk factors and typical prophylactic drugs you would give and their dosing. You can include plus or minus these other ones if you think that is going to cause an increase in postoperative nausea and vomiting in this patient. But like I said, the evidence is plus or minus. So if the patient has 0 risk factors, it's about a 10% chance that they will have postoperative nausea and vomiting. You typically give plus or minus 1 drug. Most people will give 1 drug, and most people will give ondansetron, 4 milligrams IV. Key thing here, remembering that it will prolong your QT. If the patient has 1 risk factor, they have about a 20% chance of having postoperative nausea and vomiting. For these patients, we typically give 1 to 2 drugs. So you will typically give ondansetron plus or minus dexamethasone, anywhere between 4 and 8 milligrams IV. Now remember, dexamethasone will also increase your blood glucose levels, so be cautious of that in patients that are diabetic. If the patient has 2 risk factors, they have about a 40% chance of having postoperative nausea and vomiting, and you're typically going to give 2 to 3 drugs. So you would give ondansetron dexamethasone and plus or minus a scopolamine patch, or maybe a propofol infusion during the case. If the patient has 3 risk factors, they have a 60% chance of having postoperative nausea and vomiting. So here you would probably give 3 to 4. And again, I'm just going to quote this from above. You could do ondansetron, dexamethasone, scopolamine patch, and a propofol infusion if you wanted to get 4, or maybe you would just do a propofol infusion if you just wanted 3. Again, it's 3 to 4. Most people will probably do 4 here. Or you could even give maybe a little bit of diphenhydramine. Typically 15 milligrams IV. 15 milligrams. If the patient has 4 risk factors, they have an 80% chance of having postoperative nausea and vomiting. You typically give 4 drugs, so you may give Zofran, dexamethasone, scopolamine patch, or give a propofol infusion, maybe some diphenhydramine, or you may also give another drug, which is a prepitant, and you give that preoperatively. And the typical dose is 8 milligrams PO. So that's my general approach to patients with post-operative nausea and vomiting. I try and give them drugs intraoperatively or preoperatively to help prevent it, because it's really unpleasant when patients wake up and they feel nauseous and they're vomiting. We'll talk about what drugs we give for postoperative nausea and vomiting in the postoperative care unit in a little bit later. But essentially, they're the same drugs. You're just giving them at a different time, with the exception of a prepitant that has to be given preoperatively. So now let's talk about postoperative nausea and vomiting in children, because the risk factors are a little bit different. And in general, children typically have a less incidence of postoperative nausea and vomiting. There's 2 patient-related factors and 2 environmental factors. The patient-related factors are 1, a family history of postoperative nausea and vomiting, or even a personal history if the child is old enough, and age greater than 3 years old. That being, younger children typically don't have as much postoperative nausea and vomiting. The 2 environmental factors are types of surgery: strabismus surgery and surgery greater than 30 minutes. So now let's go through the same table. If the patient has 0 risk factors for postoperative nausea and vomiting, they typically have about a 10% chance of PONV, and you typically only give plus or minus 1 drug, and that would be ondansetron. You're typically giving 0.1 milligrams per kilogram. Max dose, 4 milligrams. If the patient has 1 risk factor, they really only have about a 10% chance still of postoperative nausea and vomiting. So you're probably going to give just 1 to 2 drugs. So you may give ondansetron. Don't know why I put a G in there. Typically going to give ondansetron plus or minus dexamethasone, 0.1 milligrams per kilogram. Max dose, 4 to 8 milligrams. Once the patient has 2 risk factors for postoperative nausea and vomiting in children, now their risk factor increases, so they have about a 30% chance of PONV. Here you'll typically give 2 to 3 drugs, so you may give ondansetron, dexamethasone, and maybe a propofol infusion. the patient has 3 risk factors, they have about a 50% chance of PONV. You may give 3 to 4 drugs. Here you may add on diphenhydramine. Typical dose is 0.5 milligrams per kilogram. Again, max dose is typically 15 to 25 milligrams. If the patient has 4 risk factors, they have about a 70% chance of PONV. You may give 4 plus drugs. So here you may add on, for kids, typically we add on droperidol. And it's 10 to 15 micrograms per kilogram, with the max dose being 1.25 milligrams. Droperidol also increases your QT, so they have to be monitored. It has a black box warning, so the patient has to be admitted and monitored if you use that drug. So now down below, I have included antiemetic timing for prevention of postoperative nausea and vomiting in adults. There's a large list of drugs, their dosing, and their timing. On the right, we have antiemetic dosing prophylaxis for children and their drug dosing and max dosing. The last thing that I'm going to finish on is this table, is this kind of flow chart that runs you through an algorithm of how to deal with postoperative nausea and vomiting. But essentially, it kind of goes through things we've already talked about. If the patient has a medium or high risk, then you're going to think about 2 or 2 plus interventions to help with postoperative nausea and vomiting. And I'll let you kind of read this and go through. It's pointless for me to kind of just read this text. But I just want to emphasize one last thing. Treatment options. In the PACU, if you've given the prophylactic drug and they are still having postoperative nausea and vomiting, you can only re-administer, better said, you should only re-administer the same drug class after it's been 6 hours. So if a patient has postoperative nausea and vomiting in the PACU and you gave them Zofran 30 minutes ago before they woke up, the strategy and the recommendations say not to give another dose of Zofran. You'd have to use a drug that's in a different class, maybe like diphenhydramine, or maybe droperidol, or Halidol, or maybe a scopolamine patch, or perfenazine, or perfenazine, or dexamethasone. And the other key thing is we don't re-administer dexamethasone or scopolamine. So if you've given dexamethasone or scopolamine for your PONV prophylaxis, the patient has PONV in the PACU, even if it's been already 6 hours since the drug was administered, we do not re-administer dexamethasone. You do not re-administer scopolamine. And then the other thing that I mentioned here, if you use droperidol in children, they must be admitted to the hospital because they have to monitor their QT because it is associated with prolonged QT and has a black box warning of sudden cardiac death in these patients. So there are the kind of strategy to treat and prevent PONV. Hope you enjoyed this lecture.